Hello, my name is Konstantinos Papadopoulos. I'm a cardiologist from Thessaloniki Interbalkan Medical Center. First, I would like to thank Dr. G for the honor to participate in this very nice Congenital Heart Disease Congress and congratulate her for the faculty and the program. In the next 20 minutes, we're going to talk about the use of 3D and 4D echocardiography in congenital heart diseases. First of all, I would like to tell you a few things about 3D echo. The first attempts for 3D echocardiography were back in 1970s, but we had to wait for at least 2 decades in order to have an increased computing power and acquire nice 2D images. So these were the first attempts for 3D echo, but as we had the evolution of the computers and the probes, we were able to acquire nice 2D images and after that, nice 3D images. So at the moment, we only use very small transthoracic and transesophageal echo probes for both 2D and 3D protocols. The concept of 3D is to move from the area to the volume, and in order to do that, we have to stitch different cardiac cycles and take a full volume 3D dataset. For example, this is a mitral valve where you can see that we have the azimuth level, we have the elevation level of which is the depth of the mitral valve, and this is the volume rendering view of the structure that we want to appreciate. There are several papers that show that if we take just one full volume 3D dataset, all the measurements that we will do with these 2D images that we will be acquired correlate very well with the standard 2D protocols that we use in daily practice. For example, this is a full volume data set. We have included the left ventricle, the entire left ventricle, the mitral valve, the appendage, and the aortic valve. We can rotate, we can change our view, and we can demonstrate whatever we want. For example, here you can see the mitral valve. So what are the indications of 4D echo in 2023? Of course, accurate estimation of the left ventricle and the right ventricle for volumes and ejection fraction, evaluation of valvulopathies, congenital heart diseases, and transcatheter interventions, a very important field. In this presentation, we are going to focus on congenital heart diseases, and we know from the guidelines that we have a simple congenital heart diseases, moderate complexity and severe complexity. But we know that from all this spectrum of congenitals, when we use echocardiography, and especially 3D echocardiography, we have to focus only on the simple lesions. Most publications are for shunt lesions like ASDs and VSDs because 3D can give an unfast view of the atrial septum very clearly and understand, for example, if we have one single ASD, if we have, for example, a fenestrated septum. But when we have more complex diseases, then we should use all cardiac imaging modalities like cardiac CT or cardiac MRI. So when we use 3D echocardiography, we focus on valvulopathies, several congenital valvulopathies. We focus on shunts like ASDs, VSDs, or PDA. And the most important when we use 3D is to know our machine and to know which data set to use. As a rough comment, you should all know that when we appreciate a chamber, we use the full volume technique. And when we appreciate a structure like a valve, we use the 4D zoom technique because that way we can increase the spatial and the temporal resolution of our images. So in valvulopathies, apart from pulmonary valve, that it is very difficult to appreciate with 3D echocardiography because it's a very thin valve and the position is not optimal for 3D echo, we can clearly appreciate the aortic valve, the mitral valve, and the tricuspid valve very well. In aortic valve, we know that the normal valve has 3 cusps, the right coronary cusp, the left coronary cusp, and the non-coronary cusp. And this is an image of a patient with 3D transesophageal echo, where we definitely can give an answer about if it is a tricuspid or a bicuspid, for example, aortic valve. Bicuspid valves this is considered to be the most common congenital disease in the world. Here you can see two different patients, one with a true bicuspid valve with 3D demonstration, and one patient with three cusps, but with a rough between the right and the left coronary cusp. And of course, apart from bicuspid valves, we also have unicuspid valves. This is very rare. In my experience, I have only seen one patient. This patient, you can see that there is only one commissure and only one cusp. Only one cusp. And with 3D echo, we can appreciate that we have a commissure there, but on the other side, we have the cusp that it is on the air. Doesn't go towards the annulus of the aortic. About mitral valve, mitral valve prolapse is considered to be a congenital disease. So if we include it in the congenitals, so I think that this is the most common disease between congenitals. But we also have other malformations of the mitral valve, like cleft double orifice mitral valve, mitral ring in Schwann complex, a hammock, parachute, or congenital mitral stenosis. We can appreciate all these anomalies with 3D echocardiography very nicely, because we know that with 3D echo we can take the surgeon's view with the unfast view of the mitral valve from the left atrial perspective. We can also demonstrate the subvalvular apparatus with the chordae and the papillary muscles. We can appreciate a cleft very nicely. Here you can see a cleft of the posterior leaflet, a deep indentation that goes all the way towards the mitral annulus. And for prolapse, we know that 3D images correlate very well with the ones that the surgeon has during the operation. And we can give answer about the phenotype of the valve, if it is just a fibroelastic deficiency with a ruptured chordae, if it is a Barlow disease, or if we have, for example, MAD, mitral annular disjunction. These are 4 different patients. This is a patient with A2 prolapse with a ruptured chordal. This is a patient with P3. You have to know that we take as a marker, as a landmark, the aortic valve at 12 o'clock, and then we know that close to the aortic valve we have the anterior leaflet, and at the opposite side we have the posterior leaflet. So this is an A2, this is a P3. P3 and A3 are towards the tricuspid valve, and close to the appendage we have A1, B1. This is a patient with Barlow disease. You can see multiple scallops prolapsing, a very big valve. And this is a patient, a rare patient with medial commissural prolapse. You can see that we have the commissure that is prolapsing. It's not the posterior, it's not the anterior leaflet. Only with 3D echo we can appreciate very clearly these abnormalities, and we can tell the surgeon exactly what to do in planning the patient. Going from the mitral valve towards the tricuspid valve, we know that tricuspid valve is very close to the sternum, so it is better to acquire images with a transthoracic echocardiography, especially with 3D, because with 3D, we can take this unfast view of the valve. We have landmarks like aortic valve and the septum, and we can name the 3 leaflets: the septal towards the septum, the anterior leaflet close to the aortic valve, and the posterior leaflet just opposite to the aortic valve. But now with 3D, we understand that we might not have only 3 leaflets, but we might have even 4 or 5 or even 6 leaflets. Like this patient that came a few weeks ago, you can see that there is no coaptation between the leaflets in this 4-chamber view. We have torrential TR, of course, a huge right atrium. And with 3D, we can appreciate that this is a tricuspid valve with 4 leaflets. And you can clearly see the indentations between the leaflets 1, 2, 3, 4. We don't know exactly how to name these leaflets. For sure, this is the septal, but this might be A, anterior 1, anterior 2, and posterior. Other people would name these like septal 1, septal 2, or posterior 1, posterior 2, but doesn't make any difference because we know that this is a torrential TR. The management does not change. We wouldn't anyway go for transcatheter intervention in this patient. When we have shunt lesions, again, 3D echocardiography can give a very accurate estimation of the volume overload, either of the left ventricle or the right ventricle. We know that left ventricular ejection fraction and volumes correlate very well with the cardiac MRI. In patients with VSDs or PDAs, for example, we should always measure the left ventricular volume. And in patients that we have RV, right ventricle volume overload, we can accurately measure the volumes with 3D echocardiography very nicely. But of course, as a rule, we should have very nice 2D images at baseline. In ASDs, let's mention at first the PFO. I'm not sure that it is included in the congenitals, but I can very quickly tell you how to manage patients with PFO. It is a tunnel between the atrial septum, the septum primum and the septum secundum. And of course, we start with a bubble study to confirm the presence of PFO, like this patient you can see with Valsalva maneuver. And then there are several criteria indications for occlusion in high-risk PFOs and in patients with ESUS, embolic stroke of undetermined source. This was a patient with aneurysmatic atrial septum. You can see it clearly in these 3D images where we have the aneurysm of the septum. And the PFO, we measure the tunnel in short axis and bicaval views. And then we decide about the PFO occluder. We guide the interventionist with 2D and 3D images, go through the PFO, the guide catheter, and the opening of the discs with the short axis view. We don't want to harm the aortic valve. This is the left atrial disc, this is the right atrial disc, and this is the final evaluation with color Doppler and again bubble study with the Valsalva. You can see that we have very few bubbles that will go away after the visualization of the device, of course. And this is the final estimation with 3D images. You can see that the right disc is always bigger in PFO occlusion from the left disc. But when we go to real ASDs, atrial septal defects, we talk about ostium secundum, which is the most common one, ostium primum, sinus venosus, and coronary sinus. ASDs allow blood to come from the pulmonary veins directly to the right atrium, and they develop right heart failure with arrhythmias and exercise intolerance. And it should be diagnosed very early because we don't want our patient to develop pulmonary hypertension and right heart failure. There are several guidelines with the algorithms. We should measure the pulmonary vascular resistance, the roots, and we don't want to close an ASD in a patient with Eisenmenger physiology. About imaging in simple ASDs, we should use the transthoracic echo, of course, for QP to QS and volume overload. And if we cannot demonstrate the ASD, we should use the transesophageal echo. In my opinion, TOE should always be used in order to measure the correct size of the ASD and the rims. And what is the role of TOE? We should identify if the defect is present, what is the type of the defect. We have to measure the rims and the size of the defect. We have to see about coexisting congenital abnormalities, imaging for transcatheter intervention, the hemodynamic effect of this ASD, and of course, evaluation after the repair. We have a protocol from 0 degrees to 90 degrees in 45 degrees, of course. We measure the rims, we have 6 rims. The rims should be ideally more than 7 millimeters, or at least more than 5, except for the aortic rim. We don't care about the aortic rim. And of course, we have to check for pulse wave Doppler for the direction of the flow. And we have to check the pulmonary veins and if the IVC rim is present. We start from 0 degrees. We have the atrioventricular rim and the pulmonary venous rim. We go to short axis view. I will go through these slides very quickly. We have the anterior and the posterior rim. And in bicaval view, we have the superior and inferior vena cava rim. We can use triplane views in order to demonstrate simultaneously all the rims of the ASD. But it is necessary, in my opinion, to always to use a 3D anfas of the septum, because we might recognize the presence of multifenestrated ASD. We can accurately evaluate the size and the shape of the ASD. You can see here different patients. This is a multifenestrated, very complex ASD, cannot be occluded with a transcatheter device. A very small ASD in an old patient, an oval-shaped ASD. So with 3D, we can appreciate different sizes and shapes of the ASD. We can be more accurate in measuring the maximum diameter of the ASD, like this patient, because in 2D, we might lose the exact maximum diameter of the ASD. In 2D here, it was measured at 24 millimeters, whereas in 3D, it was measured at 29. These measurements are very useful for the correct sizing of the occluders. We usually go with an ambulator occluder with 2 discs. And in guidance, 3D is also very important. This is a 20-year-old female patient with a known ASD. QP to QS was 2.5, all rims present and candidate for ASD occlusion. You can see here the 2D views, the 3D view of the septum with a valve shape, which was measured at 12 to 20 millimeters, the maximum diameter. So we always guide the device implantation with 2D and 3D images, the guide wire, the balloon sizing, very important, especially when the rims are very thin, because the ASD might expand when you implant the device. So we always use the balloon sizing at the moment, with a very strong correlation, of course, with 3D images. And then we go through the device, we open the left atrial disc, we go towards the septum with a short axis view, we open the right atrial disc, we check that all rims are between the 2 discs, very important before the release. We do the tag test to check the stability and not embolization, and then this is a final result where you can see that the septum is between the 2 discs, and we don't have any problem with the surroundings of the device. In VSDs, finally, we can also use transthoracic and transesophageal echo. This is a case of VSD occlusion from the radial artery. We published with Professor Giannakoulas and Dr. Dzikas recently. And you can see here we have an ASD, a perimembranous ASD. We went through the radial artery. This is the 3D images where you can see this is the ventricular septal defect. We can recognize that there's a defect there, but to be honest, it is very difficult with just the 2D images to measure the sizing. But we can use color Doppler for the vena contracta area, for example, or the minimum and maximum diameter, as we did here, and it was 7 to 7 millimeters. So we used an Amblager duct occluder 2 from the radial artery, and this is the final result, very nice, with almost total occlusion of the VSD. So in concluding, you can see that congenital heart diseases demand a very close collaboration between interventionists, surgeons, and cardiac imagers. we should be able to use all imaging modalities, especially in complex diseases. A 3D echo is in our routine practice for shunt lesions, for simple congenitals, or valvulopathies as well. And we all need to train and practice 3D echo in order to be able to guide in diagnosis and management patients with congenital heart disease. Thank you very much for your attention, and I hope I covered all aspects of this demanding presentation.